Well, good afternoon and good evening, everyone, from wherever you are. I am out and about, so I've had to introduce Sarah from my travels. I'm in rainy Manchester. I hope it is sunny. Where Liverpool, where Sarah is in Liverpool, which is just 30 miles down the road from myself. I've known Professor Coupland for many years through the Pathological Society of Great Britain and Ireland. Um, she's an extremely renowned pathologist. She's the George Holt Professor of Pathology at the University of Liverpool, consultant pathologist at Royal Liverpool Hospital, specialising in ocular melanoma, other ocular tumours, different AI for diagnosis of ocular melanomas, and also works in ocular lymphomas and CNS lymphomas. Uh, I would spend the whole hour talking about her achievements. You can look at them on the web. So without further ado, I'll pass over to yourself, Sarah. And thank you very much for providing this hot off the heels from travel back from Taipei yesterday. Thank you.
Oh, thank you very much, Richard, for the very kind introduction. So I'll share my screen now and start the presentation. So I've just got to find it. Okay, share. Put it in presentation mode. So hopefully everybody can see that. So yes, I'm a general histopathologist and I subspecialized in ophthalmic pathology, hematopathology, and also neoplastic skin pathology. Today I'm going to be speaking about ophthalmic pathology, and I'm going to try and convince you that it is a very interesting area to undertake if you're in a trainee or even a consultant pathologist who wants to do a deep dive in eye pathology. So on the front of this screen, you'll see 3 textbooks, which I highly recommend and give very good overviews of what eye pathology is all about. On the right-hand side here, you can see the WHO classification of tumors of the eye, and this is not the latest version. The 5th edition will be coming out hopefully very soon next year. So just to explain the arrangement of ophthalmic pathology in the UK, it's sponsored by a special pot of the National Health System. So that there are 3 ocular oncology centres in England, which are based in Liverpool, Sheffield and London, and running parallel to these are 3 ophthalmic pathology services. In addition, we have an ophthalmic pathology service in Glasgow and in Manchester, which is where Richard was speaking from just now. So when we say ophthalmic pathology, we're essentially speaking about anything in and around the eye, with perhaps the diameter of reading glasses or sunglasses. So that this would include then lesions of the eyelid, the conjunctiva, then intraocular lesions involving the iris, the ciliary body, and the choroid, which is, so the iris, ciliary body, and the choroid represent the uveal tract, which is the middle layer of the eye. And then we also have tumors and lesions which involve the vitreous and the retina. And lastly, but certainly not least, are the lesions which affect the orbit and the associated lacrimal gland and lacrimal gland drainage system. So, and here, you know, are just the diagnoses to these different lesions. So what I'm going to do is try and give you an overview of all of these different tumors which can arise at the different locations. However, given the time constraints, I realize that I won't be able to go into every single one. So just starting with the top 10 eyelid lesions. Now you have to remember that the eyelid essentially consists of the epidermis, so the skin side of the eyelid, and then it comes to the region of the eyelashes, and then we've got the undersurface of the eyelid, which is lined by the conjunctiva. And we have what is called the tarsal plate, and within the tarsal plate we have the sebaceous gland units, which can be seen here. So arising from the eyelid, you have a number of lesions which can arise either from the epidermal side or the conjunctival side, and indeed can occur within the tarsal plate and arise from a range of the different apocrine, ecrine, and sebaceous glands. So let's start off with the most common ones. And so xanthelasma, I'm sure, is a lesion that you've probably seen on patients or on people. And this is essentially represents an accumulation of macrophages which are filled with lipids and can be surrounded by an inflammatory reaction, can be quite extensive, involving both the upper and the eyelid. Then we have a squamous papilloma, and they're essentially like epidermal skin tags or papillomata that can occur anywhere, and there are varying degrees of it being exophytic or sessile, as in other locations. Very common lesion which you may yourselves have suffered from is a chalazion, or a stye is a term given in lay language. And this is essentially a chronic inflammation and surrounding the fat droplets which are secreted by the sebaceous glands. And they form sort of lipid granulomata, and with or without sort of a foreign body reaction. Then we have nevi, and nevi can affect both the upper and the lower eyelids, typically well circumscribed, and more often not ulcerating, and can be just purely dermal, or can involve the overlying epidermis and so be a compound nevus. So classic sort of morphology of a nevus, and similarly with the immunohistology, which I'll show later when I demonstrate the conjunctival nevi. There are special types of nevi which can occur also in the eyelid, such as this blue nevus, which is illustrated here clinically, very dense and has a dark black bluish coloration to it, and is characterized by these heavily pigmented nevus cells, and can show a typical sort of wedge-like arrangement. Then we'll move on to some cysts. So there are a number of cysts which can occur, but the most common one is the hydrocystoma. And this is characterized, and this can consist of one chamber, but can also be multi-chambered, or multicameral is the term which is given. And it is composed of typically 2 rows of cuboidal epithelium within the cyst and filled with a clear fluid. But they can be quite large, and they can grow quite rapidly, giving the impression of rapid growth, and can be obviously cosmetically annoying or irritating. So also we have capillary hemangiomas, and this is that more often not they occur in children or in babies, and have the classic morphology of a hemangioma, capillary hemangioma in other locations, and more often than not are well circumscribed and can be removed surgically. However, if they're large, then they can be treated also in addition with either medication, so intralesional injections, interestingly, of rituximab has led to the regression of some of these tumors, these hemangioma, or, although rarely given, is a low dose of radiotherapy. More often in perhaps the middle-aged to elderly population, you can have seborrheic keratosis, and these can be pigmented and non-pigmented, and the pigmented ones can mimic, obviously, melanomas. More often not, they can just be excised as an eyelid wedge resection, and they have the typical morphology of these squamous eddies within the basal proliferation of the epidermis. And in Caucasians, you can also get the basal layer of the lesion showing hypermelanosis. So moving now into the malignant lesions of the eyelids. These are the, the most common is the basal cell carcinoma, and these really can be small, relatively well circumscribed lesions with the central rodent ulcer, as it's called, or they can be quite extensive and lead to eyelash loss. And they can also occur close to the nose in the region of the so-called caruncle, and can really cause quite extensive damage if not caught early. So they represent approximately 70 to 90% of all malignant lesions of the eyelids, and have the variety of different morphologies. The nodular, nodulocystic can also be the infiltrating or morphic form, and the subtype has to be given with the report, and all of the margins have to be addressed. So more often than not, an eyelid wedge resection is performed, and with the specimen is typically sent with a marking suture for orientation purposes, so that when giving out the report, you can say whether the medial or the lateral or the inferior margins are clear of the tumor cells. More often than not, slow-mo surgery is undertaken, and so that should the margins be involved, then an additional re-excision can be undertaken. And just to highlight this, when orientating the specimen, it's important to recognize what is the epidermis, i.e. the anterior surface, what is the conjunctiva, what is the superior margin, and what is the inferior margin. More often than not, you can identify this via the use of the marking suture or the presence of eyelashes. Another lesion which is can be very, very aggressive are the squamous cell carcinomas. They are less common than the basal cell carcinomas. However, they can be very aggressive and can require extensive surgery. Like squamous cell carcinomas in other locations, they can vary between a well-differentiated to a poorly differentiated carcinoma. And they can also lead to destruction of the eyelashes and also the periocular structures such as the caruncle, and may invade bone and cartilage. What is really important to differentiate squamous cell carcinoma from is a sebaceous gland carcinoma, which arises from the sebaceous gland units of the tarsal plate. And what is important to recognize this foamy cytoplasm, which is present in these lesions. So you can have sebaceous carcinoma in situ, but then you can have the invasion into the adjacent stroma. In the past, it was recommended that the specimen be sent as a sort of an urgent sample, such that Sudan red staining could be undertaken to demonstrate the oil within the cytoplasm. However, in the meantime, as you probably are aware, there are antibodies which allow for the demonstration of the lipid particles within the cytoplasm, and this is in the form of adipofilin. So the typical panel that we use is EMA, Bayer EP4, and the adipofilin, and the Ki67 demonstrates the how many cells are in the process of cell cycling, and really is evidence of this very aggressive tumor. What is important with these lesions is that they can be multicentric, and furthermore they can spread via pagetoid spread within the surface epithelium. So this is a massive, poorly differentiated and necrotic sebaceous carcinoma, and this is the corresponding macroscopic specimen. And you can see not only the sebaceous carcinoma cells within the orbit, but also at the limbus being the junction between the cornea and the conjunctiva. And you can see the spreading of the tumor cells within the epithelium, and also the involvement of lymph vessels. So this is a very aggressive sebaceous carcinoma, which led to orbital exenteration in this patient's case. So I was hoping to reduce all of these lesions to the top 10. However, there are two additional lesions which I think are important to highlight. First of all, melanoma in situ of the eyelid, or which would be in other locations termed lentigo maligna. However, it's you can see the melanoma in situ here, and then also the invasive melanoma. So invasive melanoma of the eyelid can spread onto the conjunctiva and vice versa because of the close proximity of the anatomical structures. Another lesion which is very aggressive is a Merkel cell carcinoma, which is a primary neuroendocrine carcinoma of the eyelid, which is characterized by this small blue cell morphology on H&E. The positivity, you can't really see at this magnification, I'm sorry, of cytokeratin 20. It shows typically the sort of dot-like expression. And similarly, you may get a dot-like expression of neuroendocrine markers such as chromogranin and synaptophysin. You're probably aware that Merkel cell carcinoma is associated or can be associated with the polyoma virus. So let's move on to the conjunctiva. So the conjunctiva is that which lines the bulbar surface of the eye, and also the fornices, that is the junction between the globe and the eyelid, as well as the eyelid, the back surfaces of the eyelid. They're called the palpebral conjunctiva. And so we have a range of conjunctival lesions which can occur, which arise from the epithelium, others which arise from the melanocytes within the epithelium, and then we have lesions which arise from the stroma within the conjunctiva. So similar to the eyelid, we can have squamous cell papillomata, and there are a number of different lesions which I'm going to show you shortly, which arise from the epithelium, and then other lesions which arise from the melanocytes. So just moving through these. So sorry, these are the various stromal lesions. And when we consider the stroma within the conjunctiva, it is quite rich in terms of its blood supply. It has a large number of lesions which can arise from the fibrous cells. We have nerves within the conjunctival stroma. We also have can have the development of lymphomas. But I'm just going to go through some of these to highlight them so that we can you can see the most common lesions. So a conjunctival papilloma, it is slightly different to the squamous cell papilloma of the eyelid in that it still contains the goblet cells of the conjunctiva, which can be highlighted in the PAS. Because they can be exophytic and grow quite large, they can develop a squamous cell differentiation and can on the surface can even show keratinization, as you can see in these two images on the right. They can be associated with an HPV virus and typically HPV 16, and this can be stained for. In the region of the caruncle, you can have the development of an oncocytoma, which can lead to sort of a papillary-like lesion. However, once it's excised, then it's quite classic in its morphology, with these trabeculae of very very pink cytoplasm, which is a result of the dense mitochondria which are present within the cytoplasm of these lesions. Exceptionally rarely, really exceptionally rarely, you can get transformation of the oncocytoma into an oncocytocarcinoma, but it is rarely seen. Now, something that I'd like to speak about are the squamous lesions which can arise on the conjunctiva, and something in which the clinicians called ocular surface squamous neoplasia, which I think pathologically we can be a bit more precise and say that this is conjunctival squamous intraepithelial neoplasia and ultimately forming invasive carcinoma. So what happens is that you get the conjunctiva undergoes squamous metaplasia with varying degrees of keratinization, and simultaneously you get varying degrees of dysplasia of the predominantly the basal layer. So you get the mild and the moderate, and then ultimately the severe dysplasia of the conjunctival epithelium, and then ultimately you get the invasive carcinoma. So this is what the clinicians would subsume under this term of OSSN, but really I think when we receive the samples we should be more specific and give the term conjunctival squamous intraepithelial neoplasia, and then give the grade of the degree of dysplasia, whether it's grade mild, moderate or severe. And this is examples of, these lesions can be quite extensive. As you can see here, this is an unusual surface of the conjunctiva, and it's been excised in toto. And you can see that the epithelium shows significant dysplasia. And what is really important in such specimens is to exclude invasive growth. Here is a case of an invasive squamous cell carcinoma, and you can see these very prominent blood vessels, or feeder vessels as they're termed, which to this lesion. More often than not, these ophthalmologists then have to go in and try and excise this completely, and then bring the edges of the conjunctiva back together, and once they've healed, then apply either a plaque or cryotherapy to ensure that the tumor has been removed completely. In this case, you can see it really is poorly differentiated, and it turned out to be a spindle cell carcinoma. So this is the epithelial lesions, and now moving onto the melanocytic lesions. We can have benign nevi, we can have pre-invasive melanoma or melanoma in situ, and then we can have invasive melanoma. So just starting with the conjunctival nevi, they're very similar to what I showed you before in the eyelid nevi. However, more often than not, within the conjunctival nevi, you have these cysts. And these cysts vary in size, and also lining the cysts, you can have numerous goblet cells which secrete mucin. And as a result of that, you can get a rapid distension of a nevus, giving the false impression of malignancy. They can be just purely stromal, but more often than not, they are compound lesions. When we look at the immunohistochemistry, obviously the cysts and the overlying surface stain with cytokeratins, but you tend to get superficial expression only of HMB45, whereas you get a homogeneous staining of melan A and also of other melanocytic markers such as S100 protein or SOX10. So let's move to the pre-invasive melanomas, and I just want to introduce you again to another clinical term which you may have encountered already. So the clinicians tend to use the term PAM, primary acquired melanosis, which was first introduced in the WHO by Bob Folberg. However, over time, it has been proposed that this terminology is not really suitable for when describing the history or the pathological changes occurring in the eye in these samples. So essentially it represents conjunctival melanocytic intraepithelial neoplasia, such that you do get a proliferation of atypical melanocytes, which can occur as nests or as confluent nests, as seen here. And they can occupy either the basal third or half of the epithelium, or involve a greater width, such that you get complete replacement of the epithelium. And you can also get pagetoid spread, similar to what you may see with the sebaceous carcinomas. So we proposed a scoring system to correlate with the clinical term PAM, with or without atypia. We also introduced this concept of conjunctival melanoma in situ, which surprisingly wasn't in the TNM staging system until the 5th edition. And over time it has been modified such that it has been defined such that it doesn't require the full thickness sloughing off of the cells, but can be defined early if you have the presence of either isolated or confluent atypical melanocytic nests. In the meantime, the WHO, the latest version of the WHO, has taken on this grading system, however, has suggested to group the CMIN scores of 1 and 2 into a low-grade group, 3 and 4 and 5 into a high-grade group, and then scores above 5 as melanoma in situ, and then obviously invasive melanoma. So this was proposed in the latest version of the WHO, and it since has been validated via a number of multi-center studies. So just moving on to invasive melanoma, relatively rare but horrible tumors. They can invade quite, they too are a bit like sebaceous carcinomas in that they can be multicentric. They can occur with invasive nests of melanocytes. They typically invade lymph vessels and also capillaries. And in contrast to nevi, you have this homogeneous staining of HMB45 and obviously also of the other melanocytic markers such as melan and SOX10. This is an extensive conjunctival melanoma which required an orbital exenteration. And you can see that these lesions can be can be small at the front of the eye and can invade also the eyelids, but can be really quite extensive in the orbit and lead to proptosis of the eye, or forward pressing of the eye. And as I mentioned, it can typically invade lymph vessels and capillaries. They spread via both means and can involve the lymph nodes within the parotid gland or the cervical gland. And what is important to note also is that they have BRAF mutations in up to 50% of the tumors. And this is very similar to what is seen in skin melanoma. So just please, if you can remember this one fact, conjunctival melanomas and skin melanomas are more similar in terms of their genetic alterations than conjunctival melanomas and the intraocular melanomas, the so-called uveal melanomas, which have completely different genetic alterations. So just looking at the stromal lesions, and there are a couple that I'd like to highlight, and these are non-neoplastic lesions, but are sent very often into eye pathology labs, and these include pyogenic granuloma, which actually is a misnomer because these are not granuloma at all. They represent an acute inflammatory response with dilated and ectatic capillaries. More often not, they lead to also ulceration of the surface of the conjunctiva. Lesions which occur with increasing age and also with increasing sun exposure are pinguicula and also pterygia. And these, you can see the extent of solar damage as highlighted in these. What is important is to look at the overlying epithelium. There is often a keratinization, a squamous keratinization of the conjunctiva. So that is abnormal. And what is important to look out for is the presence or absence of any dysplasia, because you can imagine, because of the sun exposure, you can get the dysplasia as a result of the UV irradiation. And then you can get odd lesions which mimic tumors, and this is an example of juvenile xanthogranulomatous. And you can see here the two-ton, numerous two-ton giant cells, and this bubbly cytoplasm within the macrophages, which we can then highlight using immunohistochemistry. So this juvenile xanthogranuloma case mimicked, in a way, the sort of the salmon patch that you can get with conjunctival lymphoma. And of the lymphomas which can occur in the conjunctiva, the most common one is the Malt lymphoma, i.e. the malignant transformation of the marginal zone B lymphocytes. And these are small cell B cell lymphomas which demonstrate a plasma cellular differentiation. Here you can see in the PAS stain with the presence of Dutcher bodies and Russell bodies. Virtually, the vast majority of lymphomas which occur in the conjunctiva are B cell lymphomas. So the Malt lymphoma stain with CD20 and also with CD79A. They also show an aberrant expression of the T cell marker CD43. And as you can see, the proliferation rate in the marginal zone is really quite small, typically between 5 and maximum 10%. And this is just to highlight the latest version of the WHO lymphoma classification, the 6th edition, which shows that the two volumes of this classification. And yes, you can demonstrate the monotypical expression of light chains. In this case, it was the kappa light chain. But if need be, you can go on and use the heavy chain immunohistochemistry, here demonstrating the monotypical expression of IgM. If further required, you can also go on and use IgH-PCR and demonstrate that the B cells have arisen from one single monoclonal population. A number of people have looked at the different chromosomal translocations and also mutations within Malt lymphomas or extranodal marginal zone lymphomas in different locations, as you can see here. And what is interesting is that there is a specific one that is associated with the ocular nexa, the conjunctiva, and that is the TNF-AIP3 mutation or deletion associated on chromosome 6. And this leads to the uncontrolled proliferation of lymphocytes as a result of the NF-kappa B activation. And this, I just would like to highlight, not only outlined in detail within the WHO, but also in 2 publications in leukemia in 2022. It's important to differentiate the Malt lymphomas, particularly of the conjunctiva, from reactive lymphoid hyperplasia, which demonstrates that this is a polyclonal proliferation of both B and T cells, and that there is no aberrant expression of any T cell markers. And it's also important to differentiate any conjunctival Malt lymphoma from other small cell B cell lymphomas, such as a mantle cell lymphoma or a follicular lymphoma. Obviously there are other lymphomas, large cell B cell lymphomas, which can occur in the in the conjunctiva, but more often than not, they also involve the orbit, and they include diffuse large cell B-cell lymphoma and both Burkitt lymphomas, which can be sporadic or endemic. So let's just move to the intraocular tumors, and I'm just conscious of time, and so we'll try and get through not only these but also some orbital tumors, and if there is time, I'm more than happy to take questions. So when it comes to non-neoplastic lesions, we can have within the eye, we can have choroidal hemangioma, and this is an example of one. This is an OCT, an optical computer tomography image, and it shows the thickening of the choroid. What is this layer here is the associated sclera, and this is the choroidal hemangioma is similar to what you see in other locations. This is a choroidal osteoma, and you can what is highlighted here on the ultrasound is this this area of bone. So this is a bone which is present within the choroid, causing this shadow behind the behind the sclera, so this is the anterior part of the eye, just to explain what you're seeing here. And then this is an extensive vasoproliferative tumor which is occurring at the back of the eye in the region of the optic nerve, and you can see it's really quite extensive and involves the retina. And so these are retinal vessels which have been tangled or entrapped within this large vasoproliferative tumor, which is a proliferation of the cells, the gliotic cells within the retina. So I'm moving now to the melanocytic lesions, and this is a choroidal nevus. Now, nevi are very, very common and are being picked up more often in high street optometry and optician practices, and it's actually hardly ever that we see nevi histologically, but this is an example of a nevus where you see these spindle cells which don't show any atypia, and they differ to their malignant counterpart, which is a choroidal melanoma. And so just to highlight this, what is happening here is that you have a melanocyte which undergoes a mutation in the GNAQ or GNA11, and this leads to the formation of a nevus. But then for this to continue on to a melanoma, additional mutations and alterations are required, and the most common ones that occur are chromosome 3 loss, chromosome 6 gain, and those which have chromosome 3 loss more often not have a BAP1 mutation in addition, whereas those have chromosome 6 gain have an IFAX mutation. And this was demonstrated, I'll just show. So melanomas can occur, choroidal melanomas can occur in the uveal tract, which includes the choroid, the ciliary body, and the iris, and most commonly occurring in the choroid. And these are the clinical images of them. They can be pigmented, but they can also be amelanotic. And what is really important is in terms of the risk for the development of metastasis is the presence or absence of changes in chromosome 3. If you have loss of one copy of chromosome 3, this tumor is then termed a monosomy 3 uveal melanoma. No alterations are disomy 3. More often not, but not always, you can have a mushroom shape. So this is the macroscopic picture of a choroidal melanoma, and they are very, very vascular tumors. The choroid itself is very vascular, and consequently, these tumors spread hematogenously. And you can see that the retina here is detached, and this is the associated or the immediately adjacent choroid, and the white is the sclera. This is the corresponding histology image. 50% of the patients develop, despite excellent treatment, either using surgical or radiotherapy means, 50% of the patients unfortunately develop metastases to the liver. At present, we do not have a cure, although there are newer therapies that have been developed more recently, which have led to prolonged survival of patients with metastatic uveal melanoma. And more often than not, it is the monosomy 3 tumors that spread. So the TCGA, the Cancer Genome Atlas, examined 80 primary uveal melanomas and subtyped them into 4 subgroups. So groups 1 and 2 are characterized by disomy 3 and either IFAX or SF3-1 mutations. Groups 3 and 4 have the monosomy 3 and more often not also have the BAP1 inactivating mutation. And you can see the Kaplan-Meier curves. So those patients with group 1 really have excellent prognoses, whereas those patients with subgroup 4 uveal melanoma unfortunately have a very high risk of developing metastases within a short time frame of the diagnosis of their primary tumor. So as a result of this, we in Liverpool undertake prognostic testing in patients who would like to know whether they have a good or a bad melanoma. The techniques which we use at present include microsatellite analysis and MLPA, which examines chromosome 3. These are DNA-based technologies and are performed on intraocular biopsies, but also on local resections or enucleations. More advanced techniques are bespoke next-generation sequencing panels, which include both copy number variation of the chromosomes, but also look at the mutations, the bespoke mutations of uveal melanoma. And these are available both commercially and non-commercially, and we were able to put a bespoke next-generation sequencing panel together prior to the pandemic, and we're hoping to be able to introduce this into the NHS, having gone through several required hurdles. However, it's important to note that there is a surrogate marker for the BAP1 gene in the form of immunohistochemistry. And if you have presence of BAP1 expression in the uveal melanoma cells, this usually means that the BAP1 gene is intact. Whereas if you have loss of expression, then this is an indication that the BAP1 gene has been is mutant. And you can see this on the basis of these Kaplan-Meier curves, which we and others have demonstrated over time. So if you don't have access to genetic testing, then you may be able to do the BAP1 immunohistochemistry, which gives you a very good indication of the prognosis of that patient's tumor. So moving on to other intraocular tumors, a very common tumor is a secondary tumor to the choroid or a metastatic tumor. And these are unfortunately associated with poor prognoses, and typically in male patients arise from the lung or the esophagus or the prostate, whereas in females it's more often not from breast carcinomas and increasingly from lung cancers. What we do in Liverpool is, if there is no known primary, then an intraocular biopsy is performed, and we undertake we perform the cytospins stained here with May-Grunewald Giemsa. We perform the immunocytochemistry and demonstrate that it is a carcinoma metastasis by using AE1, AE3. And in the case of a female, then we would typically perform estrogen and progesterone staining, reserving some of the sample to potentially perform a cell block and do the HER2 staining. We also would do the TTF1 to demonstrate it being a lung carcinoma in the case of a known primary in the lung, or if there's a suspicion of prostate cancer, then we would also perform the markers for prostate carcinoma. Just moving on to children's cancers within the eye, and the most common one here is the retinoblastoma. So retinoblastomas can occur in various stages, and I guess the classic one is this leukocoria, which can be picked up perhaps by parents who are taking a photograph of their child, and you can see this white reflex, or even a red with the loss of the red reflex with the use of a flash. However, in other countries, if the patients are in remote locations, then unfortunately the babies may present with very advanced tumors, and these unfortunately are associated with poor prognosis. As you probably know, retinoblastomas can be familial, and so can be inherited, and are associated with then a mutation of the RB gene. However, they can be sporadic and such that the RB mutation is only present in the proband, and there is no family history. I just want to go on and describe some of the way retinoblastomas grow. So endophytic growth means that the tumors grow into the vitreous cavity, towards the vitreous cavity, and there is no interruption per se of the retina. However, if they grow, for example, in this case, posteriorly, then you see that the tumor is growing into the subretinal space. What I should have mentioned in this above here is that you can have the vitreous seeding of the retinoblastoma cells, and these retinoblastomas can then percolate within the vitreous and also extend into the anterior chamber being here, just immediately posterior to the cornea. So this is a massive retinoblastoma, as you can see here. And something also classic of retinoblastomas is that they undergo necrosis when they are beyond a certain distance from the feeder vessel. And they undergo this necrosis and then can undergo calcification. And it could be the presence of this calcification which is picked up on ultrasounds when the oncologists undertake their various examinations. Here you can see the endophytic growth, the involvement of the retina, and the exophytic growth here, the involvement of the subretinal space. So what's classic also within the retinoblastomas at the higher power are the two type of rosettes. So the Flexner-Winterstein rosettes, where you can see these this sort of delineation here, and the photoreceptors, the persistent of the photoreceptors making up the rosettes, which you don't get classically with the Homer-Wright rosettes. And here are more examples of the Homer-Wright rosettes. And you can see the more often than not, you can get these multiple mitoses being present. What is really important when you're reporting the retinoblastomas is A, any involvement of the choroid, and B, any involvement of the optic nerve. So here you can see a low power magnification of the optic nerve, and there is a structure called the lamina cribrosa, which and it is the presence of any tumor cells beyond the lamina cribrosa, i.e. posterior to the lamina cribrosa, which defines whether you have extraocular growth. So here, this is so-called pre-laminar invasion. So the optic disc is involved, however, the lamina cribrosa has not been perforated or invaded by the tumor cells. However, here is an example where the lamina cribrosa is clearly involved, and you have in this square here a higher power, the retinoblastoma cells being present. So this is a high risk for the child, and in such cases, more often than not, intrathecal chemotherapy is also given. So the resection margin of the optic nerve is critical in the evaluation of retinoblastoma enucleation samples because this determines whether the patient requires further therapy. Just moving on to vitreoretinal lymphoma. This is a high-grade B-cell lymphoma. It is rare, but it is really a deadly tumor and has to be picked up as soon as possible. It mimics inflammatory conditions within the eye, and unfortunately can spread to the brain. So in the latest version of the WHO lymphoma classification, it has been put in the rubric of large B-cell lymphoma of immune privileged sites, together with the diffuse large cell B-cell lymphomas of the testis and the CNS. And this is because you can get a relapse of testicular diffuse large cell B-cell lymphomas in the eye or in the brain, and similarly, you can get a relapse of vitreoretinal lymphomas in the brain. And these are, as I mentioned, high-grade B-cell lymphomas. They tend to be diffuse large cell B-cell lymphomas of ABC subtype, or also now, according to the according to the expression profiles of the MYD88 and CD79A mutant subtypes. So just moving on to orbital tumors, and I know I've only got 5 minutes to address these. However, I just want to highlight the most common ones, and these include cavernous hemangiomas, and these can be really quite extensive and cause proptosis or a dislocation of the normal anatomy of the eye. More often than not, they do not cause bone erosion. However, if they're extensive, this can be the case. Dermoid cysts are relatively common and tend to occur in younger patients, and are characterized by a lining by the epidermis, and the cysts can be filled with keratin flakes. The wall of the cyst can contain adnexal structures such as sebaceous units, and can also have adipose structures, or they vary in their components. More often than not, they can be excised completely, and this is required in the report whether they have been completely removed by the surgeons. Then I'm going to move to some of the other lesions which occur in the eye and in the orbit, and they include the most common tumor arising in the lacrimal gland, which includes the pleomorphic adenoma. And I'm sure you've seen examples of these. So they show a variety of components, with the epithelial components and also the stromal components, and one may dominate be dominant over the other. They are typically well circumscribed and can be removed in sano by the surgeons. What is important is to look for any malignant component either within the tumor or within the so-called the pseudocapsule surrounding the specimen. And this is an example here of a carcinoma which has developed from an adenoma. Other lesions which are malignant include a diffuse large cell B-cell lymphoma. So lymphomas of the orbit, most lymphomas of the ocular adnexa, apart from the conjunctiva, typically involve the lacrimal gland, and the most common one is the diffuse large cell B-cell lymphoma, followed by the follicular lymphoma. And this is a very aggressive case, as you can see here, which also led to infiltration of the skin adnexal structures, the striated muscle, and also of the peripheral nerves. However, the patient was treated with R-CHOP and with radiotherapy, and it led to complete resolution of the tumor, and the patient actually had a very good prognosis following this treatment. Mimicking lymphomas is IgG4 related disease, and this is something that the clinicians always want excluded. And so in the case of dense lymphocytic infiltrates, perhaps with the formation of reactive lymphoid follicles, please look out for the degree of plasma cellular differentiation, and always consider doing an IgG and IgG4 stain. And there are certain criteria which are required to make the diagnosis of IgG4 related disease. And in such conditions, clinicopathological correlation is required with assessment of serological alterations. And it's also important to consider that IgG4 related disease can, with time, in a certain proportion, undergo malignant transformation into a lymphoma. So another condition which is malignant, which arises from the lacrimal gland, is adenoid cystic carcinoma, which has typically this Swiss cheese-like appearance and can vary in its degree of differentiation. It's a deadly tumor. It spreads, shows typical perineural and intraneural extension, and unfortunately the patients have poor prognosis. Last but not least is a rhabdomyosarcoma, which is again a very aggressive tumor and has the classic morphology and the immunostaining with the MD immunohistochemical pattern, and there are various subtypes which are important to be given within the report. So I hope I've not confused you with this whistle-stop tour of ophthalmic pathology. It really does provide a great variety, from skin pathology to a variety of intraocular lesions, and then really quite extensive variety of soft tissue and epithelial tumors which can arise from the different structures within the orbit. Just to say that the latest volume of the WHO is on its way. In contrast to the previous editions, it does include tumors of the optic disc, optic nerve, lacrimal gland, and the drainage system, as well as those of the soft tissue and the bony tumors, some of which I have addressed today. There is a specific chapter also on the genetic tumor syndromes affecting the eye and the ocular adnexal structures. So with that, I will conclude my presentation. I'm happy to take any questions now if there's time. Otherwise, I'm happy to also take them with via email, and my email address is provided there. So I'll stop sharing now, and we'll leave it there. So I just will also show my face. So there's one question here. What are the clinical and histopathological differences between conjunctival actinic keratosis and low-grade conjunctival intraepithelial neoplasia? Good question. I guess the actinic keratosis is more often seen on the on the eyelid, the undersurface, eyelid conjunctival surface, where it can, and more often not at the junction between the at the so-called the grey line between the junction between the conjunctiva and the epidermis, whereas the low-grade conjunctival squamous intraepithelial neoplasia is more often in the phonoceal and the bulbar conjunctiva. And and as I mentioned in the presentation, what is important is to give the degree of dysplasia within the specimen, and whether there is involvement of the margins. Okay, and I can't see any further questions, and I don't have the ability to see any hands. So with that, I think I will refer back to admin, and I believe there's going to be a conclusion to say that there won't be any presentation next week. I believe the next presentation will be in the first week of January.
Yes, thank you so much, Sarah. Our next presentation will be January 7th at the same time and the same link, with Richard Byers presenting. Thank you all so much for joining today, and we're excited to see you in the new year. And thank you so much, Sarah, again for a great presentation.
Pleasure. And just to wish everybody all the best for a peaceful festive season and a prosperous 2026.